Okay, good. Anatomy of abdomen in general. This is the trunk, the skeletal framework of the trunk. Here you find the thoracic case. Behind it the vertebral column. Below is the pelvic bones forming the pelvic girdle. And these are the anterolateral abdominal wall muscles and posterior abdominal wall muscles. And here is the diaphragm, cupola of the diaphragm. It's just like a dome. In the dome, you can find an opening here. That opening is for the aorta. Now, all this thing below the diaphragm, up to the pelvic floor, there is up to the liver trani. It is the abdominal cavity. So the upper part of the abdominal cavity is having the rib cage in front and sides and behind. Posteriorly to the vertebral column and paravertebral muscles that forms the boundary. Anterolaterally and anteriorly, the abdominal wall muscles form the boundary. So the viscera is present in the abdominal cavity. So starting from the diaphragm down up to the pelvic floor, the viscera are nicely packed inside the abdominal cavity. They are so nicely packed, though such long, tubular, soft, elastic structures are packed there inside, you rarely find obstruction to these bowels. Let us come from behind how the structures are arranged. This is the vertebral column, and these are the paravertebral muscles, and here are the ribs, and this is the pelvic bone, and the middle is the sacral bone. So in the back is the spinal column. This is the diaphragm, and here is the vertebral column. Psoas major is there on either side. It passes through the pelvic posterior wall to be inserted into the greater trochanter of the femur. And this is the iliac bone, which is clothed by iliacus muscle on either side. These are the posterior abdominal muscles, and here are the anterolateral and anterior wall muscles which were cut. Here you can see the kidneys, great vessels, lymph nodes, and the ganglia and autonomic plexus around the great vessels. The duodenum, the pancreas. So up to here, there is no peritoneum. So all these things are called as the retroperitoneal structures. The spinal column, retroperitoneal mesenchymal tissues, namely the muscles, the fascia, the areolar tissue, the adipose tissue that is there behind the peritoneum is called the retroperitoneal tissues. Then kidneys, ureters, bladder, and pancreas, and C-loop of the duodenum, as well as the ascending and descending colons, they are all retroperitoneal. This is the posterior parietal peritoneum. For the colon, of course, the peritoneum is cut here because the colon is there actually retroperitoneally. That's why that part is shown as cut area. Then we have the gut and liver, female reproductive system in females. Then this is the anterior layer of the parietal peritoneum. This is the diaphragm. Then the abdominal wall. And this is covered by the beautiful skin. So these are all the abdominal organs that are there in the abdomen. So we have to learn about all these things. We have to learn about the gut. We have to learn about the related solid organs. Then we have to study about the reproductive organs and study about the urinary organs and the abdominal wall. And these abdominal organs, they are not placed in every person in the same pattern. This is called body habitus. In some individuals, the body structure is wide. That means the shoulders are broad, the chest is broad, the pelvis is broad. The people are looks very broad. So these people are called as the hypersthenic individuals. In these people, you can notice that stomach is situated very horizontal. Transverse mesocolon is very short. So transverse colon lies very high. So all the bowels are there mostly in the pelvis. Then the extreme, it is called asthenic. The asthenic individuals, you can see stomach is hanging down into the pelvis. Transverse colon is sagging into the pelvis. Bowels, they go into the pelvis. The person is long, slender. This personality is called asthenic personality. Which is normal? Tell me, out of these four. There is hypersthenic, sthenic, hyposthenic, and asthenic. These are the four grades. Which do you think is normal? Okay. All are the normal body habitus. The shape of the individual, whether broad or long and thin, so there's all genetic. That is why there is nothing like abnormal or disease type. So everything is normal. Just to know that the disposition of the organs in the abdominal cavity is not similar in all individuals. So to emphasize that point, I'm showing this because in some individuals like hypersthenic, you find that stomach is completely situated in the epigastric region and right hypochondric region. But in asthenic individuals, you can see it is there in the epigastrium, it is there in the umbilical region, and some individuals it will be seen even in the suprapubic region. So out of these, which is more common? So more common is sthenic and hyposthenic. The hypersthenic and asthenic, they are uncommon variants. So all are normal. So just now we have seen the abdomen means it encompasses all these structures. So the main presentation of the patient with an abdominal disease is in the form of pain or a lump, distension, or dyspepsia. These three you can understand: pain, lump, distension. What is the meaning of dyspepsia? What is the dyspepsia? Tell me, what do you understand by dyspepsia? Indigestion. Very good. Any pepsia means digestion. Dyspepsia means there is some abnormality in the digestion. So when our patient feels some indigestive symptoms, they are very vague, those symptoms. Patient may say bloating or feeling fullness after food, feeling nausea, vomiting, anorexia, or pain. So all these things related to the digestion is called as the dyspepsia. Presentation of these symptoms. Abdomen is a conglomerate of many organs. The symptoms of abdominal disease are due to pathological manifestation of these various organs. Pain, dysfunction of diseased organs, lump, distension, general disturbance. That means the patient may not have any abdominal problem. Though he is having abdominal disease, he manifests with some general symptoms like asthenia, that means loss of weight. So these things may be the presenting features. So you may not find the abdominal symptom, for example, tuberculosis of the intestines. The patient may not develop initially pain in the abdomen or any dyspeptic symptoms. He will come to you with loss of weight and fever. So like that, these are the main manifestations of abdominal disease. With these features, the patients come to us for diagnosis and management. Problems with the diagnosis. It is non-pointing and misleading. That means, what is meant by non-pointing? For example, if the patient is having pain somewhere here, that means if the right iliac fossa organ is diseased, the commonly diseased organ in the right iliac fossa is the appendix. For example, if the appendix is having some inflammation, then the patient will not present with symptom of pain in the right iliac fossa. He will present to you with pain in the with pain in the umbilical region. So pain in the umbilical region is the main manifestation of the patient with acute appendicitis. That means the patient comes to you and says that he's having pain in the umbilical region, but disease is there in the right iliac fossa. That means it is non-pointing. So where this organ lies, that place, the patient may not have pain. The patient have pain somewhere else. And symptoms will be misleading. Of course, I will tell you shortly about these misleading symptoms. Signs may be minimal. So the patient may come to you with severe pain, rolling on the bed, curling. But when you examine him, you may not find any sign or very minimal signs. We have seen it in the acute pancreatitis in the initial stages. So in the first day of attack, if you examine, you may find mild tenderness, but patient will be groaning with pain. That is why patient may need elaborate investigations to diagnose the case. How to overcome these problems? Sound knowledge of anatomy and physiology of abdominal organs. Detailed history taking of all abdominal organs. Methodical clinical examination. Understanding and correlating the various clinical signs to pathology. Interpretation of the symptoms to the abdominal disease. If a patient comes to you and say he is having pain, how are you going to interpret that pain, and how are you able to deduce that the pain is produced by this particular organ in the abdominal cavity? So now let us see how we interpret the symptoms. The pain in the abdomen, it is produced by somatic structures like abdominal wall, parietal peritoneum, visceral structures, gut, solid alimentary tract, genitourinary system. What do you understand by somatic and visceral structures? What is the difference between them embryologically? What is somatic structure and what is visceral structure? What is somatic structure? First tell me. Somatic structures are derived from ectoderm and mesoderm also. They are called somites. That is why it is called somatic structures. Visceral structures are developed from endodermal tube. That is called the guts. What is the difference between them? The ectoderm will be there, and inside, in the middle is the mesoderm, and innermost is the endoderm. This endoderm forms into a tube. From this tube, the alimentary tract and related structures are developed. The ectoderm and mesoderm overlaying, they form the wall. they form into somites. They get the nerve supply from the spinal cord. They migrate and they form various structures over the abdominal wall and outside. So, somatic structures means those structures that develop from the ectoderm and mesoderm are called somatic structures. The visceral structures are the structures which are developed from the endodermal tube. The somatic structures are innervated by the spinal cord and cranial nerves. The visceral structures are supplied by the autonomic structures, autonomic nervous system. That means the sympathetic and parasympathetic system. They supply the the nerve supply to this viscera. And the pain also can be due to viscera that is there in somatic compartment. For example, pancreas and kidneys, they are in the retroperitoneal area. The peritoneal cavity is called the visceral sac of the abdomen. All the structures that are there in the peritoneal cavity are the viscera of the abdomen. But some viscera are there outside the peritoneal cavity also. They are the pancreas, kidneys, ascending descending colons, and duodenum. In addition to this, pain can be produced due to functional disorders like psychosomatic problems. A patient may be having some psychosomatic problem, that is, he may be having some severe depression due to some problem. So that with that depression, the patient may feel pain, or he may feel dyspepsia, he may feel even diarrhea, or he may get anorexia, nausea, and vomiting. So the abdominal symptoms, what we have just discussed, can be a manifestation of some psychological disorder without any organic problem in the abdominal cavity. The organs are perfectly normal, but patient is having symptoms. So these are all called the functional disorders. Can you tell me some example for this functional disorder? Some disease, what do you call the disease? Yes. IBD is different. As irritable bowel syndrome, that is called IBS. IBD means inflammatory bowel disease. So there is inflammation there. So this is called IBS. Very good. Any other disease is there? Similar to the IBS, in the upper abdomen, there is the for foregut disease. This is somatization only. Psychosomatic problem is somatization. The functional problem, if it is felt as a somatic disorder, it is called somatization. There is one more condition called non-ulcer dyspepsia. Apart from irritable bowel syndrome, there is one more condition called non-ulcer dyspepsia. The name itself tells you there is no ulcer, there is no peptic ulcer, but patient will have symptoms just like peptic ulcer. That is why that is called the non-ulcer dyspepsia. So that is again another functional disorder. What is the difference between somatic and visceral structures? Let us see now. Somatic structures are innervated by somatic nerves, and hence pain from these structures is well localized and precise. When you look at the sensory system is there for the only somatic structures. That means structures developed from the ectoderm and mesoderm. They only have the nerve supply to appreciate the sensations of pain, touch, vibration, heat, cold, etc. The visceral structures, they don't have a pain perceiving system. That means the sensory system is absent in the visceral system. In the viscera, the nervous system is developed for reflex mechanisms. There will be efferent fibers which carry the impulses to some center, and that center will give some orders. They will be carried by efferent nerves. They come to the motor system or secretory system of the viscera and they do the function. So they are only for efferent and efferent systems. They are for the internal function of the gut. So that is the visceral nervous system. The gut and other viscera are innervated by autonomic nerves. Hence, the pain is not felt because there is no pain receiving center there. But the patient will feel the pain, how the pain is diffuse and vague and not localized to the site of the organ, but felt deeply at some other place as determined by its sympathetic innervation. So this sentence looks very complicated. Anyway, I will explain it in the next slide. If, for example, just now I told you, if the appendix is swollen, the appendix is situated in the right iliac fossa. When it is distended, then patient will get pain. And where the pain is felt, not in the right iliac fossa, but in the umbilical region. Why? Why the difference is there? Because of the autonomic innervation. For example, you have a patient, you give local anesthesia to the abdominal wall to do surgery on the abdomen, not general or spinal anesthesia. That means his mind is completely awake. He is knowing whatever that is happening around. So you just anesthetize the abdominal wall, only wall. Then make an incision and cut through the abdominal wall structures. Then you encounter the bowel, stomach, and various viscera in the abdominal cavity. You take a knife and cut the stomach. Will the patient will have pain or not? You have not given anesthesia to the stomach. You have given anesthesia, that is local anesthesia, to the abdominal wall only. So you cut open the abdomen, you are seeing the stomach, with a knife, you make an incision in the stomach. Will the patient complain of pain or not? You tell me that first. So I have seen mixed response. Almost equal response. Some said pain will be there, some said there is no pain. To tell you the truth, patient will not have any pain. If you cut it, patient will not have pain. But when you hold the stomach and pull into the abdominal wall, what you are doing? You are causing stretching of the stomach. When you stretch the stomach, patient gets pain. That means when you pump in air and distend it, patient gets pain or discomfort. When you cut it, when you touch it with a hot needle, patient will not have pain. So the usual pain sensations, pain producing things like touch, pain, heat, cold, they don't produce sensations in the viscera. Only the spasm of the muscle, the stretch of the muscle of the viscera, or ischemia of the viscera, or stretch of the mesentery, they only produce pain. All the other things do not cause pain. That is why you can do safely any surgery on the abdominal organ by giving local anesthesia to the abdominal wall, provided you have not stretched the organ, you have not stretched the mesentery, then you can do it. When you stretch the organ, that means due to distension, or the organ is spastic, or the organ is ischemic, then it produces pain. So where the pain is referred, the pain is felt not at the place where the organ is there, but it is felt over the dermatome of the same spinal segment. Now my video, is it visible now? My video, is it visible now? Why some problem is there? Okay. Are you able to see me now? No? Okay. I will just refresh. Are you able to see? How is my audio and video? Okay. Okay. Okay, that's fine. So, the pain produced from viscera is only for certain types of stimuli only. The regular and routine stimuli which cause pain over the skin or muscle, they are not causing pain for the viscera. Spasm, distension, stretch of the mesentery, ischemia. These only produce pain in the viscera. Number one. Number 2 point to note is the pain is not felt in the place of the organ. The pain is felt over somewhere else. Where? Over the dermatome of the same spinal segment. That point I am going to describe now. Visceral pain referred to as dermatome. Now let us see. These are the viscera. Here is the spinal cord. These are the posterior horns. This is the anterior horn of the spinal cord, gray matter. This is the anterior nerve root. This is the posterior nerve root having the dorsal ganglia. You can see the nerve, peripheral nerve. For example, from the umbilical region, this nerve is coming, let us suppose. So this nerve is going like that, divided into two branches, anterior trunk and posterior trunk. This is posterior trunk, this is anterior trunk. Anterior trunk ends in the anterior horn, posterior trunk ends in the posterior horn. That's fine. Now, when you look at this main trunk of the nerve, peripheral nerve, after the nerve emerges from the spinal vertebral canal, it comes out. It gives a twig that is called the gray rami communicantis. It comes and anastomoses with paravertebral sympathetic ganglia. There is a chain of ganglia situated on the side of the vertebral column. How many of them are there? Tell me. How many ganglia are present? Sympathetic ganglia. How many sympathetic ganglia you find? There are altogether 17 ganglia are there. 3 in the neck, 11 in the chest, that is called thoracolumbar, and 4 in the lumbar. So this is also called thoracolumbar trunk, sympathetic trunk. This sympathetic trunk has these ganglia. So there are about 11 ganglia in the thoracic system. These receive the nerve fibers from all the thoracic spinal nerves. These thoracic spinal nerves, they give the fibers to this ganglia. So these fibers, they get the sympathetic fibers from the hypothalamus. They come through the spinal column, spinal cord, and they emerge out through these nerves, through these spinal peripheral nerves. And they leave the peripheral nerve through this gray ramus communicantis. They come to the sympathetic ganglia, there is paravertebral chain, and the synapse with ganglia that are present here. Then the postsynaptic fibers, they travel through different nerve trunks. There is a routine pattern of this sympathetic ganglia. Now, the nerve fibers that are coming to the abdominal viscera, already I told you, there are no peripheral nerves supplying the gut. The gut is supplied by autonomic nerves. Autonomic nerves means there are sympathetic nerve fibers and parasympathetic nerve fibers. The parasympathetic nerve fibers, they come through vagus nerve. The sympathetic fibers comes through this system. Now we have parasympathetic ganglia here. The abdominal viscera, they get the nerve supply from 7th to L2 spinal ganglia. That means there is paraspinally there is a chain. The chain is having various ganglia. The ganglia that gets the nerve from the 7th spinal segment. 7th spinal segment gives a nerve. For example, suppose this is the 7th segment. It gives off the nerve, sympathetic fibers. Through this anterior trunk, the sympathetic fibers come. They come through this and the synapse here and fibers come out. Like that from 7, 8 and 9, the nerve fibers, they come out and form a nerve called greater splanchnic nerve. From 10th, 11th, nerve fibers come out and they form lesser splanchnic nerve. From 12th, L1 and L2, there is one more nerve coming out that's called the least splanchnic nerve. So we have seen greater splanchnic nerve, lesser splanchnic nerve, and least splanchnic nerve. The greater splanchnic nerve comes and joins the celiac plexus. That means plexus of, you have seen in the image, aorta is there, you have seen plexus of nerves in front of the aorta. That is the autonomic nerve plexus. So that nerve plexus gets fibers from the vagus nerve, it gets nerve fibers from the sympathetic ganglia. That means greater splanchnic nerve goes and joins the fibers that are situated around the celiac artery. That is called the celiac plexus. The lesser splanchnic nerve goes and joins the superior mesenteric plexus. The least splanchnic nerve goes and joins the inferior mesenteric plexus. Is it clear? Or shall I demonstrate with a drawing? This is the spinal cord. And on either side, there is paravertebral chain. That means there will be ganglia for this chain. Now, the gut is here. Now the nerve fibers, they come out of the spinal cord, the synapse here. From there, the branches leave the this is T7, here is the T9. So fibers coming from T7, T8 and T9, the synapse in the paravertebral ganglia and the efferent fibers, they join together to form a nerve. That's called the greater splanchnic nerve. From the T10 and T11, the nerve fibers, efferent fibers, they join together and they form a nerve called the lesser splanchnic nerve. From T12, L1, sometimes L2, it gives a nerve called the least splanchnic nerve. In front of the aorta, we have seen nerve plexus. Let's suppose this is the aorta. In front of the aorta, there is a plexus around the celiac artery. That is called celiac plexus. Superior mesenteric artery, there is a plexus called the superior mesenteric plexus. Inferior mesenteric artery, there is a plexus called the inferior mesenteric plexus. These are the three main vessels which supply the gut: celiac artery, superior mesenteric artery, inferior mesenteric artery. Please remember that. So around these vessels, there is plexus of nerves. The plexus of nerves gets the nerve supply from the sympathetic system. Greater splanchnic nerve goes and joins the celiac plexus. From there, the nerves will go to the structures that are supplied by the celiac artery. That is the stomach and proximal part of the duodenum. Then the lesser splanchnic nerve supplies the superior mesenteric plexus. From this plexus, the nerve fibers will go and join the structures that supplied from the superior mesenteric artery. That means the small bowel and ascending colon and right 1/3 of the transverse colon, right 2/3 of the transverse colon. Then the least splanchnic nerve goes and joins the inferior mesenteric plexus. From there, the fibers goes to the gut that is supplied by the inferior mesenteric artery, namely the descending colon, sigmoid colon, and rectum. That means T7 to T9, that means the spinal segments T7, T8, T9. From there, from the anterior horns, the sympathetic fibers come and ultimately they go to the stomach and upper duodenum. From T10 and T11, the fibers will go to the small bowel and ascending colon, that means right side of the colon. From T12, L1 and L2, the fibers will go to the descending colon and rectum. So this is how the sympathetics are innervating the gut. What is the function of the sympathetic system? The sympathetics, they are mainly the efferent system. That means the sensations that are there in the gut, they are carried to the spinal column. From there, they go to the hypothalamus. The hypothalamic ganglia, there are the autonomic ganglia are there. Then they control. For example, stomach is distended. These impulses carried to the autonomic ganglia. The autonomic ganglia sends impulses to the vagus nerve, and vagus nerve will cause digestion and increase the motility to empty the stomach. So whatever that is happening in the gut is perceived by these efferent fibers, and they carry these impulses to the brain. The brain in turn automatically causes the efferent action. So for this reason, these sympathetic fibers are present. So they are the efferent fiber. That means they carry impulses from the alimentary tract to the brain. Okay? I hope up this point this is clear. Am I clear? Okay. Now let's come to this image. This is the spinal cord. This is the anterior root. And these are the sympathetic ganglia. The sympathetic ganglia are giving the branches which form the plexus. We can see the plexus because various nerves are coming and joining here. This is also called celiac ganglia, or it is called superior mesenteric ganglia, or inferior mesenteric ganglia. So there are three ganglia in front of the aorta. The three ganglia receive nerve supply from the sympathetic nervous system through paravertebral chain as well as from vagus nerves. Okay? From these ganglia, the fibers pass to the alimentary tract as small, minute branches accompanying the blood vessels. Celiac artery gives off branches. So along those branches, these fibers, these autonomic nerve fibers go to the gut. Along the superior mesenteric artery branches, the branches go to the gut. Inferior mesenteric artery, the same thing. So there are no separate branches you see from these ganglia. These ganglia give off branches which go along the blood vessels and supply the viscera. Now, these are the branches that are coming along the blood vessels supplying the viscera, let us suppose. Now there is some problem in the intestine. The intestine is very distended or getting a lot of spasms. So then what happens? These efferent impulses are carried to the brain. The efferent impulses go like this, go to the ganglia, from here to the paravertebral ganglia, from there they are carried in the nerve, from there to the anterior root, and they go to there, and from lateral spinothalamic tract they pass upwards into the brain to the basal ganglia of the brain or hypothalamus. Okay, then when the hypothalamus perceives the pain, no, it doesn't feel the pain because there is no pain center there. Pain center there in cerebral cortex. These fibers don't go to the cerebral cortex. That's why patient doesn't feel the pain. But how the pain is felt? Now, when these fibers are carrying those efferent impulses like this, now you can see this is the peripheral nerve carrying the impulses, sensory impulses from this particular dermatome. So this area is supplied or receives this particular nerve gets the sensory supply from this particular area of the skin and muscles. So these fibers are going like this. That means these are the pain carrying fibers of the skin and the muscle. That means abdominal wall. The abdominal wall pain fibers are going like this to the dorsal root ganglia, posterior horn cell, then they cross to the other side, they go to the cerebral cortex, postcentral gyrus, and they feel the pain there. So when these pain fibers here from the gut are passing, now these fibers and these fibers, they are almost admixed. That means the impulses are not mixed. These fibers are all in close contact to one another. So because of this close contact, some of these impulses are carried on these pain carrying fibers. So for example, this is 10th spinal segment. 10th spinal segment supplies the superior mesenteric ganglia. Superior mesenteric ganglia supplies to the small bowel. That means small bowel pain is carried to the 10th thoracic paravertebral ganglia. From there, they go in the 10th thoracic nerve to the spinal cord. So 10th thoracic nerve also gets the pain fibers from the umbilical region of the abdominal wall. So umbilical region of the abdominal wall, the pain fibers are carried in the same nerve. So now this impulse is carried on to these pain carrying fibers. So now patient feels as if pain is there in the umbilical region. I hope you understand this point. So when pain is there in the small bowel, patient feels that pain is situated in the umbilical region. This is because of jumping of these impulses to the pain carrying fibers. And these pain carrying fibers get this response or sensory stimulus to the brain. And that's how the patient feels the pain as if it is there in the umbilical region. Did you understand this point? Okay. So this is called the referred pain. Actually, pain is not there in the umbilical region. It is referred. But how this pain is felt, it is not as sharp as the somatic pain. For example, if you pinch somewhere here, I am closing my eyes. Someone comes and pinches here. Then if you ask me where he has pinched, then I will show that this is the place, exact place I can show you. But when small bowel gets spastic, the patient gets pain in the umbilical region. Then you ask him, Where is the pain? He will not show with the tip of the finger. Instead, that he will show you with the palm of the hand. So this is all the area I am getting the pain. That means he cannot pinpoint where the pain is there. That pain is felt very diffusely, very vague, and looks as if it is somewhere deep, not in the abdominal wall. But pain is felt in the umbilical region. But pain is not exactly in the umbilicus. Where? Somewhere deep. How? Vague, diffuse. So he will show always the pain of visceral pain with all the four fingers and the palm. Somatic pain, he will show you with the index finger. He will just show with the tip of the index finger, this is the pain, this is the area of pain. That is how he shows to you. So that is the difference. The visceral pain is felt only if the organ is stretched, spastic, or ischemic, or due to stretch of the mesentery. Now let us see how the sympathetic nerves supply the gut. This part of the intestine is developed from foregut, lower end of the esophagus, stomach, duodenum first part, and second part up to the entry of the papilla of Vater. So this part is developed from the foregut. The artery to the foregut is celiac artery and its branches. The nerve supplies are from, it is T7, T8, and T9. Its function is digestion. From the papilla of Vater and the duodenum to downwards to the whole of the small bowel, to the appendix, ascending colon, hepatic flexure, right 2/3 of the transverse colon. This all thing is developed from the midgut. The artery of the midgut, the superior mesenteric artery through its branches. Nerve supply T9 and T10, function is absorption. Left 1/3 of the transverse colon, descending colon, sigmoid colon, rectum up to dentate line in the anal canal. It is all developed from the hindgut. The artery of the hindgut is inferior mesenteric artery. Nerve supply is T11, T12, and L1. Function is evacuation or excretion. So please make an imprint of this in your brain. If you want to learn about abdominal organs disease, you must have this as a background in your brain. Then you can understand all the abdominal symptoms very easily and efficiently well. I repeat once again. This is the foregut supplied by celiac artery. Arteries are T7, T8, and T9. This is the midgut area supplied by superior mesenteric artery. Nerve supplied by T9, T10. Then this is the hindgut supplied by inferior mesenteric artery. Nerve supply is T11, T12, and L1. Okay. You can just make a change here. Nerve supply, just add 1. This is wrongly printed here. Anyway, I'll correct it here itself. I've corrected it here. So this is how the nerve supply comes to the gut. Foregut, midgut, and hindgut. Now let us see how the spinal nerves supply the abdominal wall. T6 supplies the G-sternum level. From below up to the umbilicus, it is by T7, T8, and T9. T10 and T11 at the umbilicus and just below the umbilicus. T12 suprapubic region, L1 the groin region. So this is the way the nerves supply this particular area of the abdominal wall. Now let us see if the patient gets pain in the foregut region, that means stomach or duodenum, then where the pain is felt? The pain is felt in these dermatomes. When the patient feels pain in the midgut region, the pain is felt in the umbilical region. When the pain is felt in the hindgut region, the pain is felt in the suprapubic region. So, for example, if the patient is having pain in the umbilicus, where the pain is felt, you tell me. Pain is felt in the appendix. Where the patient feels the pain, tell me. T10, very good. Umbilicus, very good. Because it is a midgut structure, all pains produced from the midgut, either from the whether it is from the right, whether it is from the ascending colon, cecum, appendix, ileum, small jejunum, lower part of the duodenum, and their related structures like part of the pancreas, the patient feels the pain in the umbilical region. For example, pain is there in the left 1/3 of the transverse colon. That means in the splenic flexure. If the patient is having pain in the splenic flexure of the colon, patient will not feel pain in the left hypochondric region, but patient feels pain in the suprapubic region. Foregut pain is referred to the epigastric region, midgut pain to the umbilical region, hindgut pain to the hypogastric region. Gallbladder pain. Yes, in the previous image, those foregut dermatomes were one segment before. You please correct it because I have corrected in the previous image, but I have not corrected in the later image. So please consider that epigastric region is supplied by not from T6, T7, T8. It is from T7, T8, and T9. Umbilical region T10 and T11. Suprapubic region T12 and L1. Okay? Okay, that's fine. Gallbladder pain. Gallbladder pain mainly occurs due to cholecystitis. Initially felt in the epigastric region and later felt in right hypochondric region to inferior angle of the right scapula. Why this type of pain? The initial pain is visceral pain. That means because gallbladder is developed from the foregut, the patient feels pain in the epigastric region. And once the gallbladder inflammation spreads to the surrounding parietal peritoneum, because gallbladder fundus touches the anterabdominal wall. So inflamed gallbladder, when it touches the anterabdominal wall, the peritoneum of the anterabdominal wall is inflamed. So now the peritoneum is inflamed. Parietal peritoneum is a somatic structure. So the pain is well localized. So this particular right hypochondric region area, the pain is felt over the right hypochondric region, and pain passes along the dermatome of the right hypochondric region. That means along the T7 and T8 dermatomes, and patient feels pain passing circumferentially to the back. That is how the gallbladder pain is felt. Diaphragm. What is the nerve supply of diaphragm? Along with root value, please tell me. What is the nerve that is supplying the diaphragm, and what is the spinal root value? It is the phrenic nerve, okay? What spinal segments supply? C3, 4, and 5. C3, 4, and 5. Mainly 4 and 5 are the dominant. Sometimes there will be contribution from C3 also. So it is the phrenic nerve supplied from spinal, cervical spine 3, 4, and 5, because diaphragm to start with develops in the neck region. Then it descends down into the trunk. So it carries the nerve also from there. That is why it gets nerve supply from the third, fourth, and fifth cervical segments. So if diaphragm is irritated, then patient feels pain over the 3, 4, 5 cervical dermatome segments distribution. That means over the lower part of the neck and over the shoulder region, on upper part of the lateral part of the shoulder, the patient feels the pain. Here is the third segment, third cervical segment. Here is the fourth, and here is the fifth. So 3, 4, and 5. So these are the dermatomes that are affected, and patient gets pain over those regions. So this is the gallbladder. Gallbladder pain will be there from right hypochondrium to the back, to the right side of the back, along the dermatome of the 7 and 8 segments. Diaphragmatic pain is felt over the shoulder, 3, 4, and 5 dermatome segments. The urinary organs pain is referred along the L1 and L2, that is along the genitofemoral nerve. No, not both shoulders, only one shoulder, affected shoulder. The right diaphragm will produce pain in the right shoulder, left diaphragm will produce pain in the left shoulder. So this genitofemoral nerve. So the urinary organs pain is carried along this particular nerve. So the pain is felt along the course of the genitofemoral nerve, then from the loin to the groin pain. Retroperitoneal pain, retroperitoneal visceral pain, that means viscera situated in the retroperitoneum, like pancreas. We have seen in the previous class. Acute pancreatitis. Patient feels pain in the back, in addition to the referred pain on the sensory dermatome. Why? Because pancreatic pain, pancreas is developed from foregut as well as midgut. That is, a patient will feel pain in the upper abdomen, above the umbilicus. So that is the area of visceral pain of the pancreas. And in addition, patient also gets pain over the back. Why? Because pancreas is situated in the retroperitoneal region. The pancreas exudates. They come and bathe all the retroperitoneal muscles and tissues. So the patient gets pain in the severe pain in the back also. So this is the pancreatic pain, and this is on the back. Pain is also modified by the neighboring somatic structures. Example, parietal peritoneum due to the irritant action of the diseased viscera. That means in acute appendicitis, where the visceral pain is modified to pain in right iliac fossa after the exudates irritate the peritoneum in the right iliac fossa. Just 1 minute. If the appendix is inflamed, that means it swells. Because of that, the patient gets pain. So initially, the pain will be felt in the umbilical region, because the visceral pain of the appendix is felt in the midgut dermatome, that is the umbilicus. On the acute inflammation, the inflammatory exudates come out of the appendix and then touch the overlying peritoneum. The parietal peritoneum is a somatic structure. So once the peritoneum is irritated, the overlying muscles, they undergo severe spasm and they produce pain. Now the patient gets pain in the right iliac fossa. Now the fellow is having two pains. One, the visceral pain of distension of appendix. Number two, somatic pain produced from the irritation of the parietal peritoneum. Now, whether the patient will have both pains or only one pain. If the patient is having only one pain, which pain? And why pain that area only? First of all, whether the patient will have two pains or only one pain. Pain in the umbilical region, pain in the right iliac fossa. Whether we will have pain in these two places or at only one place. You tell me. Two or one. Initially umbilicus. Okay. Later. When it migrates to right iliac fossa, whether pain is there only at right iliac fossa or at both places. Later, when pain migrates to right iliac fossa, then pain is felt only at right iliac fossa or at both places. Only one place. Okay. I want to make this point clear to you that when a person is having pain originating at two places in his own body, pain is in the muscle, in the deltoid, you are giving some injection. Pain is there in the abdomen, severe colic. So two pains are there. Then patient will not feel two pains, he will feel only one pain. Which pain? The most severe pain is felt. The less severe pain is not felt. Why? Can you tell me? When two pains are there in the body, only one pain is felt, which is severe. That pain is felt. Domination only. Yes. What is that? Why? What theory is there? Is there anything related in the spinal cord controlling this pain? There is one theory. Did you hear gate theory? Gate control theory. That is right. So there is a theory called gate control theory. When two pains are there, patient feels only the severe pain and not the less severe pain. Did you ever go to the labor room? Did you conduct any labor? You must have done it. You can see the obstetrician, when she is delivering the child, the mother is having severe pain. So she will be crying with pain. And when the patient is crying with pain due to bout of contraction of the uterus, during that time, the obstetrician cuts the perineum to do episiotomy. Sometimes she won't give even anesthesia. Without anesthesia also she cuts and the patient doesn't feel the pain. Of course, this incision must be made only during the severe bout of that uterine colic. When colic is not there, you should not cut the perineum. When colic is there, then you cut the perineum. Even without any anesthetic infiltration, patient won't feel the pain. That means for a patient with severe colic abdominal pain, you give intramuscular injection. Though the injection is painful, he cannot experience that pain there. So this is called gate theory of pain. So only at one place the patient feels pain. Whichever is severe, that pain is felt. So out of the visceral pain and somatic pain, which pain is felt? Which pain is severe? Colicky pain, visceral pain is severe. Non-colicky pains, whatever it is, the somatic pain is severe. That is why patient feels pain in the right iliac fossa. But if the patient is having a obstructive appendicitis with severe appendicular colic, then patient will feel in the pain only in the umbilical region, not in the iliac fossa. That is the site of the pain. So the site of the pain is dictated by the dermatomal supply of the sympathetic nerves supplying the gut. So whichever nerves that supplies sympathetic gut, whichever nerve supply the sympathetic system to the gut, the nerves emerging from the same level, that particular dermatome experiences the pain. Then coming to the nature of the The type of pain varies according to the nature of the disease. It may be continuous pain in inflammatory conditions, colicky pain in spastic conditions. Dysfunction of the viscera. When our gut is diseased, there will be dysfunction. That means its functional status gets altered or deranged. That produces dyspepsia. If the stomach is disordered, a colicky is more painful. The stomach is disordered. How it manifests? When our stomach is having some problem, the first thing what it does is it gets the symptom of anorexia. The patient doesn't feel like taking food. So when stomach is ill, the first symptom is anorexia. If the stomach is moderately ill, not mild. Mild means anorexia. Moderately ill or moderately diseased, then the symptom is nausea. If the stomach is severely diseased, the symptom is vomiting. So there are three symptoms for stomach dysfunction: anorexia, nausea, and vomiting. There are three grades of gastric disorder. Then patient will get bloating sensation. Because there is no normal peristaltic activity of the stomach, even if the patient takes little amount of food, the stomach feels stretched, very much stretched. That's why the patient feels the bloating sensation. Small bowel, the patient gets malabsorption as the symptom, diarrhea. So that fellow will passing foul smelling, large semi-solid stools or liquid stools whenever small bowel is dysfunctional. Colon, altered bowel habit. That means instead of passing once in a day, he will pass thrice or 4 times a day, or he will pass the stools once in 4 or 5 days. So that means he gets either constipation or diarrhea. There may be discharge of mucus. The dysfunction of the liver clinically manifests to the patient as symptom of jaundice. Urinary organs, there will be dysfunction is manifesting as disturbance in micturition in form of frequency, dysuria, and hematuria. Female reproductive organs, they manifest with the feature of menstrual disturbance. So, the abdominal organ, viscera, if it is diseased, it manifests in the form of pain, or it manifests in the form of dysfunction. Dysfunction means it can be anorexia, nausea, vomiting, it can be diarrhea, it can be constipation, it can be jaundice, it can be urinary micturition trouble or menstrual trouble. Sometimes there may be modified presentation due to exaggerated sympathetic response of some organs, especially the stomach. The symptoms are modified. Just now I told you, anorexia, nausea, and vomiting are the features of stomach. Now a patient comes to you, complains of some umbilical discomfort, and he gets nausea, and after a few minutes later, he gets a bout of vomiting or 2 bouts of vomiting. So when the patient comes to you, what do you think by his symptoms? He's having pain or discomfort in the umbilical or upper abdominal region. He's having nausea and later he got vomiting. So what will be the diagnosis? Which organ is at defect? Tell me. Which organ you suspect to be diseased? Stomach. You are all right. So we'll suspect stomach. Nausea is there. That means that when nausea is there with vomiting, we'll suspect stomach only. But the problem is there not in the stomach. The problem is there in the appendix. A patient with acute appendicitis comes to you with pain in the umbilical region, with nausea and vomiting. Because nausea and vomiting is there, we will suspect that he is having some gastric problem. Because gastric trouble is so common, nausea and vomiting is there, so we suspect that fellow is having some gastritis. But in fact, the fellow is having a particular problem. Then why it is like that? It is because stomach, where stomach is situated, is first part of the alimentary tract. Its sensations will make you either to eat food or reject food. You get hunger pain, you get appetite, all because of stomach. If stomach is not functioning, you'll get anorexia. You don't feel like taking food. Even if you don't feel like taking food, your mother comes and then forces you to take something. No, please take something. So you take something and you will get nausea, and still at something you will get vomiting. That's what the stomach will do. That means stomach is in the forefront of all the organs. If some organ in the abdominal cavity is diseased, then stomach should come to its rescue and protect it. How? By giving rest to that particular organ. How rest is provided? By not taking anything by mouth. So if the appendix is inflamed, it can't tell you. It just tells you that this discomfort is there. When discomfort is there, you just take food also. But when appetite is not there, when nausea is there, you can't take food. That is why in many of the abdominal diseases, stomach behaves with an exaggerated sympathetic response. Sympathy means this kindness to his fellow members. So why it happens, all that is because of enteric nervous system. Apart from autonomic nervous system, there is one more nervous system in the intestinal tract that is called the enteric nervous system. The main leader of enteric nervous system is there in the stomach. It controls. It gets impulses from all the parts of the bowels, how they are functioning, how they are moving, how they are secreting, how they are digesting. Basing on that, it controls the other structures. If, for example, intestines are finding some problem to digest with some food, you have to take some lot of fatty food. The intestines, they are unable to digest it properly. Then it sends the impulses to the stomach. I am facing very difficulty in digesting this bloody fat what this fellow has taken. Then what the stomach will do? Okay, don't worry. So the patient will get now a lot of appetite and feeling of fullness. That's why he won't eat anything more. So the intestines now can take that load which is there and gradually and slowly digest that fat material. Once that fat is completely digested, then stomach feels comfortable. Then patient feels comfortable and he gets the appetite. Until that time, even if it is for 1 day or 1.5 days, the fellow won't get the sensation of appetite. Sometimes he may get even feeling of nausea and vomiting also. So these are all the responses of the stomach to protect its inmates of the abdomen. So this is all because of enteric nervous system, which is the pacemaker is there in the fundus of the stomach and at the pylorus of the stomach. So stomach is called as the big brother of the abdomen. It protects the other viscera by its manifestations of anorexia, nausea, and vomiting. Sometimes its response is greater than the diseased organ, and the disease is mistaken for gastric disorder. So that is about the pain and dysfunction. Sometimes the patients may manifest with the manifestation of lump. Lump is the only presentation sometimes. The site of the lump indicates the site of its origin, unlike the pain. For example, if appendix produces mass, big mass, where the mass is felt in the right iliac fossa only. So, like pain, it need not present with some other place. It presents only the site of its origin. So this is about the symptomatology of the abdominal organs dysfunction or disease. Manifests mainly as pain, dysfunction of the organs, as a lump, and as dyspepsia. Sometimes these are modified. These are modified because the autonomically innervated viscera are present in the parietal side. They are close adjacent to the parietis. Number two, the stomach behavior. Stomach may over-exaggeratedly respond to the stimuli and it manifests, and sometimes the manifestations mislead us to make a diagnosis of gastric disorder. So gastric disorder is a common accompaniment of many other small bowel disorders. So please note that point. So whenever a patient comes to with nausea and vomiting, don't focus your attention only to the stomach. Think of surrounding organs also by other leading symptoms. Pain in umbilical region also is there. Then you suspect some problem with the midgut structures. Pain in suprapubic region with nausea and vomiting means patient may be having some problem with the hindgut structure. And stomach is responding as a sympathetic response. It is showing that nausea and vomiting. I hope you understood my point. Clinical examination. Clinical examination, I will go rapidly because all of you are doing this examination. So just I will briefly touch the points. General examination, abdominal examination, inspection with special attention to the headial orifices, palpation, percussion, auscultation, and examination of both loins, examination of scrotum, supraclavicular region, and spine. So these are the steps you have to take in the examination of the abdominal cavity. So history taking, general examination, local examination. Don't stop it here. Examine both loins. That means for real angle, standardness, fullness, and dullness. Then examine the scrotum, supraclavicular region, especially the left supraclavicular fossa, and spine. So this only completes the abdominal examination. Usually when abdominal case is there, you focus only on these four things: inspection and palpation. Percussion auscultation is not done frequently by the students. So they focus mainly on these two things. So only focusing on these two things will not give you much information. You must have all these things put together, then only you can come out of the confusion of the various symptoms manifestation. The detailed history taking, already I explained to you the symptoms of the abdominal disease. So those points I have to inquire. You have to inquire about the pain, site, nature, aggravation factors, relieving factors, relation to the food, vomiting and defecation, periodicity. The dysfunction of the organs, anorexia, nausea, vomiting, diarrhea, altered bowel habit, mucus or blood in the stools, frequency, difficulty in micturition and hematuria, menstruation disorders, jaundice, fever, loss of weight, anemia, etc. So you have to inquire about the pain, you have to inquire about dysfunction of the viscera. So that means dysfunction of the viscera means all these points you have to inquire. History taking is very, very important in abdominal examination because many of the abdominal diseases have very small findings, very little findings on examination. Much you can get by proper history taking. That's why spend some time, have some patience to elicit history from the patients. If any lump is there, then inquire the initial site of appearance, its rate of growth, associated pain, preceding history of abdominal disease, you have to inquire. Past history, personal history, and family history. You inquire any previous histories of similar pain, past history of surgery and the abdominal cavity. So you take the personal history, inquire about the alcoholic and smoking habits and any other drugs consumption. Family history, for the similar problem, if the patient had any problem, you have to inquire. General examination, this is done to observe for weight loss, dehydration, anemia, jaundice. Examine the tongue, lymphadenopathy, clubbing of fingers, pedal edema, heart and lungs. So what you do routinely is first have a general look, whether the patient is having normal weight or whether the patient is looking very sick, ill and having weight loss. Look for signs of dehydration. That means drawn up eyes are drawn in, skin is dry and inelastic, tongue is very dry, patient is little bit restless. So when such features are there, think of dehydration. Then examine the eye. Just pull out the lower eyelid and look for anemia. Retract the upper eyelid and ask the patient look down and look for jaundice. Examine his tongue for any coated tongue, dry tongue, pale tongue, bald tongue, or any other abnormality of the tongue and oral cavity. Then examine the cervical lymph nodes on either side and both axilla and groins. Then examine for the clubbing of fingers. Then examine the pedal edema. Then finally the heart and lungs. Inspection, you look at the abdomen to look for any altered shape, that means distended abdomen, any lump, visible pulsations, visible veins or engorged veins, hernial orifices for any cough impulse. You have to examine, inspect. Then palpation. This is the most important step in the clinical examination of the abdomen. The commonly observed findings are, in many of the diseases, you cannot make out any sign. Abdomen is completely soft, nothing abnormal will be seen. Look for any tenderness in any particular quadrant. Look for rigidity and guarding. In one of the previous classes, someone was asking me about guarding and rigidity. What is rigidity and guarding? In both, there is reflex contraction of the abdominal wall over the area of abdominal pain. For example, acute appendicitis is there. When you try to examine the right leg fossa, patient will have stiffness of the abdominal wall. Why the stiffness? Because of the reflex contraction of the abdominal wall. This may be due to rigidity. What is rigidity? It is present at rest. That means even if you don't touch the abdominal wall is stiff. You ask the patient to take deep inspiration, and normally with inspiration the abdominal wall moves up. With expiration it goes in. So that's why closely inspect the abdominal wall. With each inspiration it comes up, with each expiration it goes in. If there is any part of the abdominal wall is rigid, that part will not move. There will be slight movements during inspiration and expiration. If you keep your hand, then that part will feel very stiff. That is rigidity. And what is guarding? Voluntary contraction. That means patient has some pain there. A child is there. If you want to touch his abdomen to examine because he is having pain abdomen, the child keeps the abdomen taut. That is called guarding. That is, it presents due to provocation from the pressure of examining hand. That is voluntary contraction. Rigidity is an involuntary contraction. Guarding is voluntary contraction. So examine for tenderness, rigidity or guarding, and then examine for organomegaly, for liver and spleen enlargement. If any lump is discovered, its characters are examined and its anatomical plane, whether it is intra-abdominal, parietal, is examined. If it is intra-abdominal, then check whether it is intraperitoneal or extraperitoneal. I hope all of you know this particular test very well. And this is ascertained by leg raising test and knee elbow test. One of your colleagues have asked me just now about supraclavicular fossa and spine, why to examine. Just I will tell you. Once we finish the abdominal examination, then I will tell you why you have to examine for the supraclavicular fossa and the spine. So then you examine the lump for any movement of the lump with respiration. If a lump is felt, The lump may be due to swelling in the abdominal wall or swelling in the intraperitoneal cavity organ like stomach or transverse colon, or it may be in the retroperitoneum. So how to say? Both of them, all the three are in the same plane. So when you examine, all of them are there only in the epigastric region. So whether it is arising from the abdominal wall or from the stomach or from the retroperitoneal structure, how to know that? So any of these three can produce a lump. So how to know that? Whether it's parietal or intra-abdominal, you know it by leg raising test. Whether it's intraperitoneal or retroperitoneal, you will elicit by knee elbow test. I hope all of you know these tests, but anyway, for your clarity, I will repeat them again here. A lump is felt, lump is seen here. Then ask the patient to raise the lower limb straight. Its borders become more prominent, the swelling also become more prominent, means it is a parietal swelling. Now you can see a lump here. So is it arising from the epigastric region, abdominal wall, or from underneath stomach, or from the retroperitoneal structure? For that, what you do, you ask the patient to raise the limbs straight upwards. Now, how is the lump? You tell me. Is it looking more prominent or less prominent or not seen? The first picture is the patient is keeping his legs flat on the table. In the second picture is the patient has lifted the legs straight upwards. That's why his rectus muscle is more prominently seen. The lump is seen more prominently or less prominently in the second picture. So all of you are told only not seen or less prominent, but only one student has committed that it is prominent. So that student, please check again and tell me whether it is less prominent or more prominent. Less, very good. It is less prominent. So what is your inference? Is it intra-abdominal swelling or a parietal swelling? Parietal or intra-abdominal? Yes, it is intra-abdominal. When the swelling becomes less prominent on leg raising, it means that the swelling is intra-abdominal. Okay. Is it in the peritoneal cavity or in the retroperitoneal space? Is it an intraperitoneal organ or retroperitoneal organ? That means it from the stomach because the epigastric region. Yes, you have to do other test called the knee elbow test. Very good. Lump became less prominent on leg raising, so it is an intra-abdominal swelling. So our next step is to keep the patient in the knee elbow position. Ask the patient to be in prone position, and he will be there on the knees and elbows. So on their support only, he will be staying like this. Then you pass your hand underneath the abdominal wall, feel the lump, and what you do is you push the lump towards spine. You push it like this and leave your hand and see whether the lump comes and falls on your hand or not. So this is called the knee elbow test. On the knee elbow test, when the lump is pushed back towards spine and hand is released, the lump again came along with the hand and touched the hand. That means the lump is moving. So when you push it, it goes up. When you drop it, it falls along with your hand down. That means it is mobile anteroposteriorly. The anteroposterior mobility present means it is an intraperitoneal organ. That means it is called falling forwards is positive. If you push it up, it doesn't move much. Leave your hand, it doesn't come and touch your hand. That means it is a retroperitoneal structure. So whether it's intraperitoneal or retroperitoneal is judged by this hand movement test. This is called knee elbow test or falling forwards test. In this patient, when the swelling is pushed towards the spine and dropped down, the swelling is also dropping down along with the hand. What is your inference? Is it intraperitoneal or retroperitoneal structure? Very good. All of you made correct statement. It is intraperitoneal structure. I hope these tests are very clear to you. These are very, very important tests. Usually in the clinical examination, you will be given case of lumps for your examination, in the clinical examination. Usually lump only will be given to you. In the lump means definitely you must say whether it is intra-abdominal or parietal. If it is intra-abdominal, you must say whether it is intraperitoneal or retroperitoneal. So you must know the basis of this particular test. So every student who gets an abdominal case has to do these tests. Then percussion to evaluate for free fluid in the abdomen, presence of gas-filled viscous in front of any lump, and to evaluate the upper part of the liver. Auscultation for any bowel sounds, for any murmurs, you examine for auscultation. Then examination of scrotum, supraclavicular nodes, and spine. Why to examine for scrotum? The patient may be having hernia or a scrotal lump due to testicular mass. For example, a patient may come to you. When you examine, you may find a lump somewhere here. You have made a very nice examination. You say this is a retroperitoneal mass, nodular, tender, non-tender, hard in consistency. Then you will make a diagnosis of carcinoma of the stomach. Okay, that's fine. Then you try to examine for the supraclavicular region. The patient says that, scrotum. The patient says that, no, I don't want you to reveal my private parts to you. Or you may feel shy to examine the private parts of the patient. So they are concealed. But in fact, the patient is having a large lump in the right testis. So then what is it? This fellow is a young man, about 25 years. He's having a lump in the right testis, which is solid. He's having another mass in the epigastric region. Now, what is your diagnosis? This is not an acute case. This is a chronic case. The fellow is having a lump for the past 3 or 4 months. In pancreatitis, you won't feel any lump. In pancreatitis, you will feel only tenderness, diffuse tenderness. Okay, I will ask another question. A solid lump in the testis. I don't give any other findings. A solid lump in the testis. What is your diagnosis? Tell me. Clinical diagnosis. Imaging studies may be different. Any solid lump of the testis, it is due to, if it is not tender, if it is not acute, it is due to tumor of the testis. malignancy of the testis. It may be seminoma, teratoma, germinal tumors, miscellaneous tumors, whatever it is. Solid mass of the testis means if it is painless, it is due to tumor of the testis. So in this case, it is due to tumor of the testis producing secondaries in para-aortic lymph nodes at L1 level. That means secondaries in the lymph nodes. So if you have not examined the scrotum for this patient, the diagnosis will be carcinoma of the stomach. If you have examined the scrotum, then the diagnosis will be something different, totally different. So that is why in every case of abdominal lump, make it a point to examine the testis. Understand? Why supraclavicular fossa? I will tell you in the next slide. This is the most important test which is often missed by the students, and this gives valuable information in certain diseases. So many a time students will miss this. If a postgraduate student misses the examination of the scrotal swelling, that means the postgraduate student has to come for next time to the examination. However, best he has fared in the theory examination, other clinicals, but if he does this particular point means the fellow will be failed. So please remember this. This is one of the most important things which the student has to bear in mind. Why is left supraclavicular lymph node examination? The left supraclavicular fossa is examined for the sake of palpation of the lymph nodes. Why they are so important? Why are not bothering about other lymph nodes? Because all the lymph from the below the diaphragm, this is the diaphragm, below the diaphragm, that means all abdominal organs and the lower limbs, all their lymph will flow into ultimately one structure that's called the thoracic duct. This green tube is the thoracic duct. It is having one proximal dilated area that is called the cisterna chyli. This is situated opposite L1. Here you can see celiac axis, 3 vessels coming out from front of the aorta. Just by the side of it, you will find this thoracic duct. This thoracic duct passes through the same aortic hiatus in the diaphragm. It passes upwards in the thorax. It crosses to the left side of the vertebral column. Then it goes into the neck. And then it curves around and then opens into the jugular vein, or at the junction of the jugular with the innominate vein. So at this place, it enters the blood circulation. Before it entry here, it is guarded by a valve here, because vein pressure is high. So venous blood can come and reflux into the thoracic duct. That's why there is a valve here. Now, if malignancy is there in any of the abdominal viscera, these malignant cells will come ultimately into the thoracic duct. In the thoracic duct, they are gradually passed upwards. These malignant cells, they pass upwards. Now, the malignant cells are coming here in the thoracic duct. They are halted by the valve cusp here. So over the valve cusp, the malignant cells lodge. They won't go immediately into the venous system. Then what they do, these cells here, they multiply. The multiplied cells, then what they do is they pass along the branches that are communicated with this thoracic duct. There are lymph nodes in the left supraclavicular fossa, which sends their branches to the left thoracic duct, so through thoracic duct. So through these branches, these cells, they migrate upwards and lodge in the left supraclavicular lymph nodes. Now they grow in the supraclavicular lymph nodes and develop into hard lymph nodes. So A malignancy in the testis will manifest as a mass in the left supraclavicular fossa. A malignancy in the stomach or colon or appendix or small bowel or kidney or any other structure below the diaphragm, they will have metastasis in the left supraclavicular lymph nodes. That is why left supraclavicular examination is such important point in clinical examination. If a small lymph node is there, then study about the lymph node. Hard, what is consistency? Is it discrete, tender, mobile, size? These features you must know and you must describe them. This is another point which if the student misses, the examiner takes it a very serious point. So in all the abdominal patients with abdominal complaints, you examine the scrotum, the supraclavicular fossa. Don't forget them. Then examine the spine. Of course, you examine the loin. So when you turn the patient to the back side, you examine the loin. That means renal angle. Renal angle means the angle between the 12th rib and lateral border of erector spinae. So this angle is called the renal angle. So you, with your thumb, you apply pressure. You punch it. That's called renal punch. Whether the patient has any tenderness, you percuss it and see whether there is any dullness, and you inspect it whether there is any fullness. So renal angles are examined for dullness, fullness, and tenderness. Then you examine the spine. All the spinous process has to be examined from thorax to the lumbar region, because a patient may have a problem in the spinal cord. That may cause compression over the nerve root. When the nerve root is compressed, then patient will have pain in the dermatome. So patient is having pain in the umbilical region. You think about the midgut region and examine whole of the abdomen thoroughly, and you can't get any point. But when you examine the spine, you will notice tenderness for the T10 spine. Then what does it mean? The fellow is having some problem in the thoracic 10th vertebra. That is causing pressure over the 10th thoracic nerve, and that is producing pain. That's called radicular pain. So examine the spine for any tenderness, any deformity, and any restricted movements. So these points will examine the spine. Renal angle is normally mildly resonant. It is not dull. Normally it is resonant because of the gas in the colon. So examine the spine. This fellow is having fullness in the loin region. A tender lump is there. When you examine the spine, this particular spinous process is very tender. That means, what does it mean? This is probably an abscess originating from disease in the spine. And whenever the patient, you are recording the symptoms, you make it a habit to draw a diagram like this, and you put the quadrants there. So in the quadrants, you have to mark where the patient is having tenderness, a lump, and all that. You can represent there. I hope all of you know about the abdominal quadrants, but for completion's sake, I will finish up them quickly. There are two horizontal planes. One is called transpyloric plane, other is called the transtubercular plane. Two vertical planes are there. They are the midclavicular lines, and these regions being in the middle, from above downwards, epigastrium, umbilical region, and suprapubic or hypogastric region. This is the iliac fossa, right and left. This is the lumbar region, right and left, and this is the hypochondric region, right and left. Whenever you examine, start examining for the right iliac fossa and go in a clockwise manner and examine all the quadrants, and lastly the umbilical region. If the patient is having pain in any one particular quadrant, always start examination in the diagonally opposite area. That means if the patient is having pain in the right iliac fossa, then don't start examination here. You start examining from the left hypochondric region and come like this. Because if you start your examination in the painful area, the patient will keep the muscles into voluntary spasm, that is guarding. So with that guarding, you will not be able to appreciate the abdominal lumps. Then ultimately examine for the liver and spleen. I hope all of you know how to examine for the liver and spleen. So this is the examination of the abdomen. Any doubts, please? How the pain is felt, the anatomical basis of the pain, the other disorders, how the stomach is very sympathetic to the other organs and manifests its symptoms and signs. So all this I hope you have understood. Okay, liver and spleen examination. Okay, I will tell you. If rigidity and guarding are present means the abdominal wall is spastic. Why abdominal wall is spasm? There is reflex spasm. Whenever some inflamed structure is there underneath it, the overlying parietal peritoneum is also inflamed. That causes reflex spasm of the overlying muscles. For example, if appendix is inflamed, the overlying peritoneum is also inflamed because of the adjacency. So when parietal peritoneum